Hello there, my name is Lloyd and I'm talking to you from the Field Wellbeing Centre of Junction 12 of the M4, and I'm joined by Edd Lloyd, who's one of the podiatrists working out of here. And Edd, unlike a lot of podiatrists, has chose the specialisation, and he concentrates on helping those with foot and ankle problems that are more biomechanical, more musculoskeletal. So hello Edd.
Hello Lloyd.
I suppose my first question to you is how your patients would differ from those that we'd see in more a routine podiatry clinic.
Okay, so the patients I tend to see tend to be more active, they tend to have more problems while moving. So we're looking at patients who are having pain in different types of footwear, or when walking or doing the activity they want to or love, or just generally finding their mobility getting a little bit less due to discomfort in the foot. So we look at them a little bit differently, we examine them in a slightly different way. So we're not really looking at them from a cornal callus or nail consideration. We're really looking at how limbs are functioning, ranges of motion in each of the limbs, checking their movement patterns, their walkings, their strength and their function.
Okay, that's really useful. I suppose to go into a little bit more detail, it'd be useful to look at some of the common problems that you will come across. So if we split the foot down into sort of three areas and start with the forefoot, so that's the area sort of towards the top end of the foot, towards the toes. What do you commonly see in that sort of area?
We often have something called a neuroma in that area that gives pain that will stay in the area of the ball of the foot or radiate up the toes.
Right.
It's actually a misnomer neuroma. Technically, if we want to go for the real term, it's a perineural fibroma, so it's a lump of fibrous tissue that sits around a nerve. What happens is the nerve gets compressed either from tight footwear, just general anatomy, or when the patient's walking, and the nerve kind of responds by putting a little jacket around itself. But that jacket makes the nerve a little bit bigger.
Right.
So it gets caught again and again and again, and you end up with this build-up of gristle-like fibrous tissue around the nerve. That compresses the nerve and gives pain in the area. It's often worse when it's pressed. It's a very pure pain. It's a very intense pain. We can treat it in many different ways.
Okay, is it dangerous at all?
Not at all, it just really hurts.
Okay.
So when we're treating it, we look to widen the gap in between the bones of the foot where the nerve's getting compressed. We use that using a metatarsal dome. Or a type of insole, and often footwear changes are very, very helpful. We then can, depending on what's going on in the area, if that's not successful, we can look to inject the area, so we can look to shrink the neuroma. Through that, we do that under ultrasound guidance. We use a combination of local anaesthetic and the steroid, and we're using the steroid because the steroid is really good at dissolving that fibrous and gristly tissue that sits around the nerve. And that can be very successful in around 80% of cases.
Okay.
If that's not successful, then we can refer on to surgery.
Okay. If left alone, does the sort of coating around the nerve get bigger and bigger and bigger?
It's not really size that's the problem, it's pain. Because if it's a small neuroma but causing pain, it needs to be treated. And not all neuroma are painful.
Right.
So if you look at the literature, neuromas present within 25% of the population, but not symptomatic in any of those. It's the ones that are symptomatic that really need to be treated. These neuromas are easily identified through clinical tests. We have a little test called a Mulder's click, and obviously we use point-of-care ultrasound in the clinic to help identify them readily. So they're quite easy to check out, but we only treat them if they're painful.
Oh, that's really interesting information. Any other common pathologies that you'll get in the forefoot?
Yeah, I mean the big toe joint takes a lot of stick when we're walking around. So more often you can get a bit of wear and tear in the big toe joints, so osteoarthritis in the area. And you can get these two little bones underneath the big toe joint that are called sesamoids, and they can often become irritated if they're in high pressure areas. So with those, what we do is we look to try and get the motion as best we can through the big toe joint, either using an orthotic, changes in footwear, and we either try and make best use of the motion we have, or if the motion is really restricted, we can try and block up that motion, because if it doesn't move, it doesn't hurt. If the sesamoids are involved, we can use an orthotic, an insole to go inside the shoe, take the pressure off the area. So really quite sort of simple methods.
Is this the area where people will get bunions, and is this related to bunions? Because this is something we see also in routine clinics.
I mean, bunions have a long history. Now, bunions are hereditary. Pretty much most of the time, 99% of the time, you've got a factor in your family that means you're going to get them. Now, what indicates a bunion needs treatment is not the angulation of the toe.
Right.
It's whether it's painful.
Okay.
And we can use orthotics, injection therapy, things like that to help with the pain, but it doesn't change the angulation.
Okay.
The only way you're going to get a change in angulation is to go and see a surgeon. all these little props, these wedges that you see advertised in the Daily Mail. Unfortunately, what they do is they'll make it look good while they're on, but other than that, they don't do anything. You might as well just give your money to the air ambulance. It's much better use of it.
No, it's great information. So moving away from the forefoot into sort of the midfoot area where the sort of arch of the foot is, what sort of common pathologies are you seeing with your patients there?
I mean, mostly what I do tend to see in that area is a lot of midfoot osteoarthritis, so wear and tear in the midfoot. That's probably number one condition I tend to treat in that area. There are also a lot of tendons, insertions and connections in that area, so people can get irritation of the tendons where perhaps the patient hasn't been moving particularly well, or the foot's being pushed into position because the hip and the knee aren't working quite so well together, and you can get stress and strain within those areas. The osteoarthritis in the top of the foot is normally something called dorsal interosseal compression syndrome, which is basically the bones just pushing against each other. What we do with that is we can actually try and open up the joint a little bit using orthotics or insoles, or again, if the area is really inflamed and irritated and we can see that on ultrasound, we can inject the area using a little bit of steroid, and that really calms it down, but it doesn't turn off the fact that we've got wear and tear in the area.
Okay.
With the tendon injuries, it's always about finding out which tendon is painful. So we palpate the area, have a good look around, use the point of care ultrasound to look at the tendons and see if there's any damage or inflammation in the tendons. Then what we do is we offload the tendons, give them a chance to recover, give them a break, and then we rehabilitate them. So with tendons, it's about managing load. When it's painful, we need to change the way the load moves through that structure, which means we've got to give the other structures a bit more work to do. But once we start getting the pain levels down, we can rehabilitate because tendons respond well to increasing load. So we're all about exercises. We'll involve one of the other guys here, maybe one of the osteopaths or physiotherapists to help do some rehabilitation and help that tendon recover by gradually increasing its load.
Okay, that's great. Moving back to, we see an awful lot of people that come in because of heel pain. So if we open it up, just looking at the heel pain issues, things associated with the sort of the bottom of the foot and also around the ankle, what do you tend to see there?
So heel pain, well, that's a real bag of tricks there. The term people often use is plantar fasciitis. It's one of the few words that has the double I in it, which is obviously always quite interesting. However, plantar fasciitis is actually an umbrella term when used by a lot of people. What we tend to see is something particularly called plantar fasciopathy, which is actually a mechanical injury to the plantar fascia. The fascia is a band of collagen crossing a tendon and ligament that goes from the heel to the toes. What happens is the load on that structure changes and the tendon becomes, or the fascia I should say, becomes slightly damaged. As a result, the body sends the repair team down there to try and sort it out, but the repair team isn't very good. It fills up this fibrous tissue again, and then you weight bear on it again, and that classical first step pain that you get in the morning that we see with this plantar heel pain is actually all the structures in there re-tearing. So you get this repair, re-tear process. And when we see it on ultrasound, what we see is a beautifully thickened plantar fascia. Sometimes that can involve inflammation, but very rarely, which is why plantar fasciitis, which means inflammation of the fascia, is actually an incorrect term.
Okay, now that's great. What about more sort of around the ankle area? We see a lot of people that maybe have got a history of rolling their ankles, and do you see much of that?
Yeah, a fair bit. I mean, often people we term them lateral ankle injuries or inversion injuries of the ankle, where the person consistently will roll in and damage perhaps the ligaments around the outer part of the ankle. It's often combined with other conditions, so we'll be checking the person, not just the ankle, we'll be looking at the whole person and trying to understand if there's any sort of connective tissue issues like hypermobility that could be affecting the area. We're also looking at their foot shape and foot type and trying to basically identify which structures are painful and why they're painful. Now around that area you've got several ligaments. Now three of them, the anterior talofibular ligament, the upper ankle ligament, the anterior inferior tibiofibular ligament, and the calcaneofibular ligament around the back of the ankle can often be damaged with those rolling around. So we check all of those with ultrasound, check if they're damaged. So often there's a couple of muscles that sit around the outer edge as well that try and stabilise up the ankle, and if those ligaments aren't working well, they have to overwork. So you can get something called perineal tendinopathy.
Right.
So likewise, we mentioned the damage to the tendon. When to plantar fasciopathy, tendinopathy just refers to a mechanical injury to that tendon. So that's the same thing, identify what it is, identify which structures are painful, offload them and rehabilitate them. In some cases, they need a little bit more help, in which case we'll involve other practitioners to help us with that rehabilitation, or referral onwards if needs be.
Okay, that is, again, really, really useful. You've touched on some of the things of my next question, but what sort of suite of treatments have you got available to you that you commonly use to treat these pathologies and others that you come across?
So first of all, it's always clinical evaluation.
Right.
So if you go through any podiatrist, what we specialise in is clinical evaluation of the foot. So first thing is hands-on.
Yeah.
Okay, it's checking the patient, making sure we understand which structures are involved. Now hopefully before that we've got a good history from the patient, we understand how they've been injured, how long they've been injured, what aggravates it, how much pain they're in, what they've done that helps it. So when you're looking at it, if you're not 70% sure what you're looking at and examining when you put your hands on the foot, you haven't asked the right questions as part of the history. So we're doing clinical evaluation, we tailor it for that individual. So for instance, if someone does have a big toe joint issue, for instance, we're not doing lots of investigations up around the hip and the pelvis. We are focusing it down in that area. And we're breaking things down. Each test that we do will have a little bit of evidence attached to it that tells us more information about what to look at and why that's hurting. We identify what hurts, try and identify which was the main pain, the first pain. That's namely we call it the primary pain, and we treat that. If we treat that, invariably all the other secondary pains and little niggles tend to settle down with it. But it's all really about clinical evaluation, checking, and also talking, but also using these. You've got two of those and one of those for a reason, and that's because you need to listen to that patient and what they say. If you think there's a structure that's uncomfortable when you're palpating it or when you're examining it, we can have a look using ultrasound. So I'm a qualified sonographer. I use ultrasound as point of care, so we don't really retain any images from our scans. We have a look as a chairside tool. We have a look inside the foot, check the structures, check the tendons, check the ligaments, identify which ones are painful or uncomfortable, and then tailor a treatment plan exactly for that patient, whether it be just an exercise plan, a change of footwear, orthoses, injection therapy, or if it's something we just can't help with, referral on to somebody that can.
No, that's really good in terms of clarification about what you get involved in. So hopefully our viewers have found that useful. And what I would say is, if you've got any problems with your foot and your ankle and you're a bit worried about it, you haven't got a diagnosis, you haven't got a treatment plan, come and see us. Thank you.